Coming out of the strategy, there were 5 areas identified and a cross-cutting theme for the strategy, because we felt this document and this pathway would be beneficial for all 5 of those areas of the strategy. So this is how this project was really born. But so the project is called, it's an optimal clinical pathway for polio survivors, and I'll talk a bit more as I go along as to what that means and what it's all about. But before I do that, I want to say that the project doesn't happen in isolation, and there have been some really proactive people behind the scenes, and one of them particularly, who George mentioned, has been Francis. And Francis Quinn has been the lead trustee on this project, and without her input and her expertise and her knowledge and her hard work, this project would have never happened. So although I'm presenting today, a lot of the credit goes to Francis on this. And you'll notice it's for polio survivors. So whether you have PPS or not, or whatever late effects of polio, or however polio manifests with you, it should be able to help you in some way. So yeah, so my name's Crippen Droner and I'm the Chief Exec. So thank you for the introduction, George. So yeah, basically the key people involved were myself. And although it's really only been in development for the last 2 odd years, I've been talking about this pathway for some time, and many other neurological condition charities or organizations in the UK, I'm not sure what the international picture is, has developed similar pathways to advocate for the needs for their communities. And this is why I feel I've been talking about pathways for some time. The other person who was heavily involved was Carol Levin, who's our communication manager. And she was primarily brought on the team for 2 reasons. As I said, one of our strategy teams is improving comms and to help with information with the expert panel, and in particular with this project. Francis Quinn, I've already mentioned, and she's been instrumental in getting this project over the line. But we also managed to secure the services of somebody called Hannah Burgess, who's project manager. She's worked on numerous pathways, such as FND, MND, for MND, but also cross-cutting pathways, for example, for neuro rehab, neuro mental health, etc., etc. So her skills have been very key here to ensuring the pathway gets done in the right and timely way. And then it's Simon Shaw, who was the clinical lead. We contacted the Association of British Neurologists quite early on and said you need to appoint a clinical lead. So we asked Simon Shaw. But there's been many other clinicians involved, from orthopedic surgeons, orthotic people, psychologists, physiotherapists, OTs, and I'm not going to continue to list them all, there's many others. But so we thank everybody who's been involved with this project so far. So the main thing is, what is the project? What is the problem? What is the problem we're trying to solve? And as I said before, there's a clear lack of knowledge amongst the public, but also amongst the healthcare professionals about the long-term consequences of polio. There's been a serious lack and failure in investigating these issues early. Because as a lot of you know, the quicker these issues are picked up and the quicker you get on a care pathway journey, the more likely that your symptoms can be managed better and resulted in better quality of life, hopefully. There's often misdiagnosis, so PPS is recognized as something else, or late effects of polio. And often the wrong advice is given as a result of that misdiagnosis, or even with a diagnosis. But particularly in the UK, there seems to be inadequate provision around orthotics. And again, I don't know what the international picture is. I can't see it being radically different internationally, but equally, it seems to be a big problem in the UK at the moment. And getting the right appropriate referrals to where you need to get to after that seems to be a big challenge. Many polio survivors need to travel long distances to get the care they need. And in particular, that has a big mental health and well-being challenge, which is often not being met. And there is significant and unwarranted variation in care, particularly across the 4 nations, the UK. And it's important to remember that this pathway, we want it to work in England, Scotland, Wales, and Northern Ireland. So one thing I have to say about these slides is I want to thank many people. So these slides are not just accumulation of all my efforts, but I've borrowed and, with permission, slides from other presentations people have done about the pathway. So I thank everybody who's helped me prepare these slides today. But lots, as you can see, the BPF have produced this pathway is the next step, in our opinion, for all the literature we ever produced in the past. Over the years, we produced lots and lots of things, be it the map of medicine, which you can see on the left there, the guide for healthcare professionals, a learning module for the Royal College of GPs. There's actually, Francis probably agree with me, and I think I've heard her say as well, there's nothing actually groundbreaking in the pathway. It's really the next iteration of information. It's trying to bring in everything so that there's a simple pathway for people to follow and everything in one place. This literature will still exist to inform people about either specific topics or inform people in a different way. So that's it. So we have produced a lot of information so far already, but it doesn't mean we can be complacent about it. So this slide's quite interesting in terms of where we think the problems lie. And clinicians, I'll say there's no such thing as acute polio anymore. PPS and LEOP took 50 years to be identified. The full constellation of symptoms are not recognized by many clinicians, but the experience of epidemics and aftermath have mostly retired, and we may be losing a plethora of knowledge. There's misconceptions about it being muscular rather than neurological, and muscle strength assessment can be inadequate. In terms of polio survivors, the image of the polio survivor is not a one-size-fits-all. So, you know, there's different images, and sometimes that can be challenging. It's exhausting for the polio survivor to constantly have to battle for the care they need. This is an interesting one, not often seen as tragic as other neurological conditions, even though the gambit of symptoms could be the same or worse. Many polio survivors are extremely resilient and tenacious, but as a result, they've been coping on their own, often for 50, 60, 70 years. They're the ones, polio survivors, the ones who know the best about their condition and how to advocate for their own needs in a way. And polio survivors are often invisible to the system. They often don't have polio on their records, which is a challenge to get any diagnosis for late effects of polio and post-polio syndrome. So the main aim of this pathway is to support the commissioning, design, and improvement of local pathways and services to deliver optimal care. This is the key here, optimal care, and address unwarranted variation and improve patient outcomes. But as its secondary and add-on purpose is to educate and raise awareness amongst healthcare professionals, service managers, and anybody else who's prepared to listen, really. Excuse me. So at the heart of developing this pathway has been the polio survivor. Everything we've done about this pathway has been with the polio survivor in mind, and they have been at the heart of why we developed this. So is that to ensure that they can get timely and relevant care to lead to a better quality of life, make sure that more clinicians of all varieties are aware of health issues around polio, but also to increase awareness, primarily at the moment, of the impact of polio in the UK to polio survivors, but ultimately the world, because by coming together and bringing a strong voice, it's important for a community, polio community, in my opinion. And we want more consistent healthcare across the UK. You'll see there's some timelines here which are a bit out of date. It's taken us a bit longer to produce this document than we hopefully planned, simply because we did get a vast amount of feedback when we sent the consultation document out for consultation, and making sure we do justice to that feedback was really, really important. The other thing I would say about the pathway is it's extremely aspirational. It's something that it should be the gold standard in care for polio survivors, possibly not exactly what's happening on the ground. So we can use that as a tool to say, this is what should be happening on the ground. Why is it not? Or can we make it happen? Having said that, it's not too aspirational that it's not possible as well. So what is a pathway? As a pathway is a roadmap at which people with a condition would go through their health systems, and normally it's in the form of a flow chart. So this chart tries to capture some of the multidisciplinary care that a polio survivor might need. It's quite a long list, but it's not a comprehensive list. And at the moment, if you can see from this chart, it's all a bit higgledy-piggledy. You can go from here to there and there to there, and it might not go anywhere sometimes. And you can see there's a lot of services that a polio survivor may need. And what the pathway does is shows an ideal route for a person with polio to follow through. Now, it's not as easy as that for polio people, because people affected by polio, should I say, rather, because as we discussed at another meeting earlier with some of you at, the way that people were affected by polio in the first place was vastly different. The way the effects of polio, immediate effects, the late effects of polio, and PPS has managed to manifested is vastly different. So, and as a result, this is where some of the complexities arise from. So, what does the pathway promote? It promotes a multidisciplinary, I'm going to start again that sentence. It promotes a multidisciplinary team approach to care. And I know that seems a bit obvious, but it doesn't always happen. It seems to be a case of you've got one condition, so you only need one discipline type stuff. And so this is really, really key. And that integration and coordination of that care to be person-centered. And again, seems a bit obvious, but people in this group in particular, but it's really, really important that polio person is at the center of that care. And at the moment, the difficulty of somebody with, say, for example, PPS, is the challenge of ensuring that they get the full multidisciplinary team care that they need from different departments of different health systems and different social care systems. To get that care as close to home as possible, I think is key, because traveling vast distances to get care that you need seems not very good to me. And it would ultimately give efficiency savings to health systems. So this is a very early version of the pathway, and I say that because it's been adapted a number of times since this happened. I'm not showing the latest version at the moment because it's under development, and I don't want to show the wrong thing. So this is the one. This is the version I can share because it's been sent out to this is the version that went out to consultation. And we had a steering group and a patient experience group help with the consultation to get to this point. However, whatever the basic concepts around the pathway are the same. So it basically shows a healthcare professional a flow of how a polio person should be managed in terms of care. And this side shows where that care should sit, whether it be at GP level, secondary care level, regional level, super regional center level. It tries to capture the complexity here of the different types of disciplines needed. Another really important key point here is I think every person should have a first point of contact for their care and somebody to coordinate their care moving forward. But also the important role that rehab plays here, in particular community and neuro rehab. And I think another big thing we're asking for is everybody should have a care plan they agree to with a healthcare professional, which can be followed through to ensure that they continue to get the best quality of life they can with the right care pathway in place. And there were lots of benefits and efficiency savings. The benefits would be hopefully an early diagnosis, a reduction in the number of referrals needed, reduce pressure on primary care in particular. I don't know about other countries again, but the pressure on the GP network in the UK is immense. And despite GPs doing their best they can, there is only so much time they have in the day. Hopefully we can use this as a tool to advocate for the challenges around workforce in NHS as well. Access to appropriate treatment at the right time. It ultimately reduces costs because if you're getting the right treatment at the right time, it means your costs will be less to the NHS and health systems. And there's that constant need to be reassessed. Hopefully that would reduce that. Particularly for those who are younger in the polio community, who are still of working age, if it means increased function for them, there will be less of an economic impact for their lives and a more positive impact for their lives. So that's that. So, yeah, I'm conscious I've been talking for some time, but the production of this pathway and the development of this pathway, we hope to launch it within the next few months. Once launched, to us, that's the start of the project, really. It's taken us this long to get it right, but once it's launched, the next step is getting it used, getting it adopted by health systems, getting in front of government decision makers. But the version you saw and the version of the pathway that will be released is the version that will be primarily used by clinicians, healthcare workers, decision makers in health systems and governments. We are also hoping to release another version, which is going to be a version to be used by the polio survivors in the polio community to be able to use the pathway to be to help give them a voice and advocate for their own needs. So yes, any questions?
Yeah.
Okay, if you have a question, you could please raise your hand and we'll recognize you, please. Okay.
David Mitchell, Ken.
David Mitchell.
Yeah, it's all right. He hasn't. David doesn't know how to put this, the hand up on the screen. So.
Oh, I see him. Okay, go ahead, David.
As I'm a Luddite, as they say. Hello, everybody. Very good to see 42 people present from all around. That's absolutely marvellous. My name's David Mitchell. I'm a member of the British Polio Fellowship, a polio survivor, although I caught polio rather late. I was aged 22, and I'm currently very proud to have followed such luminaries as John McFarlane as the president of the European Polio Union. I fortunately only need a stick. Obviously, when I had polio, it was very different. But a great complaint that we hear all the time, and you've noted it, Crippen, on the presentation, a great complaint is about orthotics. And I know here in Great Britain, although the health service does its best, it is possibly the #1 complaint for polio survivors about orthotics. And there was a line in your presentation, Crippen, about orthotics mismanagement. So I just wondered if this is a peculiar British aberration, or if it is echoed in other member countries of people present.
I can see lots of nodding, David, in the group to say, no, it's not a British peculiarity. It seems to be the international problem.
But I think it's vital because, of course, a good orthotic aid can revolutionize your life and improve both your health and your mental health. It means you can get out.
Right. You're absolutely right, David, that ensuring that you get the right orthotic help you need and the right aids and orthotics you need is crucial to good quality of life. And it shouldn't be seen as a luxury item. I think a lot of people see it almost as a luxury item. It should be seen as a given. And we need to do better here, not just in the UK, but internationally.
It should be part of your medical plan or your care plan, because I believe from people who need such aids that it's an absolute lifeline.
Can I briefly share a personal experience, Crippen?
Yes.
Victor. Yep.
Thank you. Just to say something fairly obvious, but nevertheless, I hope helpful. I've just had a fairly lengthy experience where 3 of my Stanmore splints didn't work out, one after the other. And with a lot of international travel and a fairly busy schedule, it was becoming very worrying. I was down to a single splint, which was getting quite rickety. I persevered and went to chief exec level within Grampian NHS healthcare. And I've since been transferred to a different orthotist who mercifully has started back at square one and recast my leg. And over the last couple of months, she's produced the most magnificent Stanmore splint. So it's a success story of perseverance, really. Gentleness, constructivity, but saying when things aren't right and getting to the end game. There's a lot of changes in technology. There's a lot of variations across Britain at the moment. And Aberdeen in particular are suffering from the lack of laser imaging, which was vetoed because it took up too much space on the IT system. So in the longer term, the NHS CEO, NHS Grampian CEO, has told me they'll look at that decision again, because making a Stanmore splint from a plaster Paris casting is actually turning into a bit of an ancient art, and the skills are not readily available in orthotists today. So in summary, technology is coming that will solve some of the problems, but with such a reducing part of the NHS demography, my sympathies go in both directions, in my direction and my fellow polio survivors, but also in the direction of the NHS, who have to make a monetary case every year on where they spend their buck. And it's a tough balancing act.
It's really good to hear that you actually had a good result at the end of it. But and it's good to share that what you said. Unfortunately, I have to say this too often to polio survivors: persevere, persevere, persevere. Because it should happen straight away. It should happen in a timely way. But unfortunately, that's what's the reality. You have to continue to persevere. But to put a slightly half glass full spin on it, if that's okay with everybody here, is at least that's an opportunity to talk about polio and get the message out there every time you're trying to persevere. So slightly half glass full, well, maybe a little bit. But I think Francis asked a question in the chat, Vic, if you can share the details of the company that got it right in the end with us, that'd be brilliant. But yeah, again, I urge you all to, as if you're a polio survivor yourself, keep persevering. I know by dint of you actually being in this group today means you are willing to talk about your polio and talk about and advocate. And this has been mentioned to me a number of times because I've been to a number of these events this week. Is you're not only helping yourself by talking about your polio, and you're helping the polio community as a whole, because everybody who finds out about it will help possibly other people as well. So
Janet,
I think
can you unmute yourself and ask your question? Janet.
Yes, hello. Hello.
There she is.
Yeah, can you comment on how we could use these pathways when our polio is, or after effects of polio are interacting with other things we have? Because when you get older, you seem to get various things, and some of them seem to interact with your polio, and the doctors aren't very clued up on that.
yeah, so this is again a question we often get asked, is how does my polio, or how does polio, the late effects of polio, PPS, interact with other conditions? Unfortunately, again, it's a very difficult question to answer, Janet. And my best answer to you is, I know this is not really helpful, but is to continue to talk to your healthcare professionals on both those conditions you may be suffering from. So I'm using that word suffering, and I know a lot of polio people don't like the word suffering, but or afflicted with, shall I say.
Well, I looked, just to interrupt you, I know about suffering and avoiding that word, but I looked it up in the dictionary, and it also means to experience. So yes. Go ahead.
So basically, I would continue to speak to the healthcare professionals managing both of those conditions, or even if it's more than one condition, to ensure that they both, your polio clinicians are aware of your other condition, and vice versa. So throw the onus back on the healthcare professional to ensure that the care you're getting is complementary in a way, to make sure that it doesn't have a detriment to your other condition. But that's, unfortunately, that's the best answer I can give you, Janet.
Thanks very much. Thank you.
Carla has her hand up. Carla, you're on.
One of the, yeah, I'm unmuted. One of the things that I was thinking about, I couldn't read your slide because my glasses are upstairs because it's early morning here. I didn't make it downstairs. But I think one of the factors is that polios need to understand that they have to travel for care. They have to possibly put out money for a place to stay when they get to care, and then travel back. That's really hard on many people in the world, even in California. And I think that idea needs to be promoted to all polios, is that when you're going, if you're going to get to a specialist, you have to expect to travel. Now, how the hotel and everything else gets paid for is, you know.
Thank you, Carla. Again, this is one of the things that the pathway does try to address in terms of the distances people have to travel to get the right care they need. And you're right, there may be occasions where you have to travel to ensure you get the right care you need. What we'd look to do, hopefully, is to say, actually, there will be certain times or certain parts of your care where you really need to go to a super center where a regional center where that's the only polio expertise available. But a lot of your other care that you need, be it physio or OT care or whatever it is, should be able to be managed locally. So the need to travel should not be multiple times. It should only have to be
An occasional trip to a specialist who's far away and you may have to pay to stay overnight.
correct. The other thing I would say is as technology develops further, it is possible that using online meetings and online and virtual meetings may become an option. I know certain things can't really work on online meetings, like physio, for example, is not ideal on online. But as technology develops and changes, it might change and become better.
If Florence has her hand up.
Yes, those of us that need home attendant care have a big problem because the ones that we use here have families, other people that they have to work with, and they cannot go. This is really a big problem. And there is no, as far as I know, agency that caters to giving a caregiver. Obviously, you pay for it when you're away from your home. That includes travel. It includes going to specialists. So it's really a major, major problem. What would be nice, and I can't speak for other countries, but here in America, if we could get some agency, organization to host a polio conference, including a clinic, get Medicare approval, and you go from Dr. A to B to C to D. And their recommendations are collated and given to you, and you go home with it. That would be ideal.
Thank you, Florence. Sounds like a good idea. I don't know how it could be made to happen. In terms of carers, yes, absolutely. Carers is a big issue here as well in the UK. Most polio survivors I know in the UK rely on family friends, mostly partners, as their carers. And many polio survivors cannot travel far without ensuring that their partner is with them, for example. So there is that thing around carers as people get older and their needs get more complex. But as I just said, often people are relying on their partners as carers. And as their carers get older and their partners get older, they're finding it difficult to provide the care, and they may need care themselves. So
unfortunately, my husband passed. He was paraplegic. My parents are dead. I have no siblings. My friends are my age, if not older. So it's becomes a problem. I remember the very first polio conference. It was called Ginny at that time. As the post-polio, I think, international. They supplied ventilators. They had doctors there. And it was fabulous. And unfortunately, it can't be duplicated.
Florence.
Just for Florence's information, when the European Polio Union did their first conference in Copenhagen in 2011, we provided exactly the same. There was equipment and everything else there because the Danish organization had all the equipment as they have their own hospital, and they hosted it.
That's great, but not now. It's just a pet peeve.
It's all right. We've just set David Mitchell a challenge. If he organises a conference, he's got to make sure there's carers and ventilators and everything else around.
Right.
I think David would end up doing the job himself if he could.
George Allen has his hand up.
Yeah, Crippen, looking forward, have you worked out a strategy for selling this idea? I use the word selling, back to your marketing experience, to the four nations?
So yes, that is going to be the next part of the project. We've been really focused on getting this pathway developed. So we just had a deadline on World Polio Day to get the final sort of sets of edits to the writing team, and then we're going to start hopefully get the early parts of designing it. It's going to be a slow process, George. I'm not going to say things are going to change overnight. The idea is in the UK, in England, is to get in front of the ICSs and ICBs decision makers, to ensure that they adopt the pathway. Slightly linked to that is there's going to be a paper out on the 7th of December in terms of how the NHS England are going to commission healthcare to ICSs and ICBs for specialised healthcare and long-term conditions. And that's happening 7th December. So hopefully we can tie in with that. And then the idea is to go to events and talk about the pathway as much as possible. So that applies to all four nations, not just England. In terms of Scotland, Wales and Northern Ireland, it's to ensure that we can get in front of the health boards and health board decision makers, to ensure that they are aware of the pathway, they're aware of the efficiencies it will save them, and they're aware of how it can be adopted. We have done one event in the Welsh Parliament, the Welsh Assembly, in June as a sort of soft launch of the pathway, and we hope to replicate events in the Scottish Parliament, the Northern Ireland Assembly, and the House of Commons Westminster Government Parliament as well. So one of the ideas is to obviously get in front of decision making via politicians, but also get in front of decision makers within the NHS systems. The other thing we're hoping to do is, another reason for part of the delay is because we want to make sure that the pathway is endorsed by as many of the relevant bodies that we can get endorsements from, such as the ABN, the BSPRM, the Royal College of Nursing, the Royal College of GPs, whatever. And hopefully when we start talking about it in Scotland, Wales and Northern Ireland, we can hopefully get their equivalent bodies in those countries to also endorse it. And also, some of you may be aware, I also sit on the board of the Neurological Alliance, and they will be hopefully also endorsing the document.
Good.
May I cut in? George, can I cut in for 1 minute? We've got an international audience here. There is a thing called the United Kingdom, but the health system is devolved into the four countries: Wales, Scotland, England, and Northern Ireland. And the other thing is that when rolls off the tongue very easy for those of us in the know, when Crippen refers to the NHS, he's talking about the National Health Service, and it is actually devolved out into each of those countries, and they control it with separate budgets.
But I mean, George mentioned when he first introduced me that the fellowship is going to be 85 years, and I think NHS celebrated 75 years. So we've been supporting polio survivors before the National Health Service. So I thought I'd just get that in there, John.
One of the things I was going to say was that we were successful in getting an MSP, that's a member of the Scottish Parliament, to put forward a motion to Parliament which to recognise World Polio Day. And we've found that, and also to recognise the work of Rotary in eradication, but also recognise the value that polio survivors have given to society. The good thing about that is that 40 of the 170 MSPs supported that. So the good thing is that there's 40 people that we can probably quite quickly get on our side. At least we can flag up that this thing is coming, and we would look forward to them in whatever roles they're in to support it and get it going. And I think that's the kind of advocacy that we need to be applying, I think.
Absolutely. Well done for that, George. Excellent result.
Mr. John, I don't know if you want to recognize a couple of the chats with your excellent rotary radio voice or not. There's a couple of good comments in there. If not, I can do it.
I can't see all the chats here. Hold on.
Okay, well, I can try if you would like.
You're going to have to, Ken.
Okay. Let me stumble through it. From Hillary, there's a comment through the work we have done with the Lincolnshire Neurological Alliance, is that the more rural the country and the fewer university hospitals, then the more difficult it is to find health professionals with the necessary knowledge. In Lincolnshire, it is not just polio survivors that have these issues, but also many others with similar neurological conditions.
I've also got the ones here. I've got it now, Ken. Hillary has also said that she had some very poor service locally in Lincolnshire for many years. Then she was referred to Kingsmill Orthotics a while ago, and sorry about that. And then she got a different she got an assessment, and what a heck of a difference the assessment made through provision of equipment. So sorry about that. People phoning me up. Somebody who's actually on this morning's meeting was phoning me. The Neurological Alliance. Anything else?
I think there's something from Francis there.
There is somewhere. Yeah. Somebody just come up
That said, the pathway raises the issue that polio history needs to be taken into account in managing condition as we get older, such as arthritis, etc. So I think that was in relation to Janet's question.
Okay, very good. So is there any other questions? We're coming to the last few minutes of the meeting. If anybody has any other questions. Kriplin, if somebody wants to get in touch with you, how do they do that?
I'll put my email address in the chat, or I'm happy for you to give out my email address to anybody who asks for it, Ken.
Okay, sounds good. And as always, of course, we've recorded this meeting and we will be sharing it within the next week with everybody. If there's no other questions, I'll thank you very much, Kriplin, for giving us all that outstanding information, and the work that you're doing is much appreciated by everybody, and so glad that you were here with us today. Terry family. Terry, yeah, do you have a question?
Yes, we're in New York City, and I just want to know, is this a weekly meeting or a monthly meeting? I would like to join again.
Yeah, sure. Terry, we meet on a monthly basis. We have a mailing list, and if you send that to, what's the email, John?
ppsadvocacy@gmail.com.
Okay, I have had a problem with emails lately. So if you send your there, we'll get you on the mailing list, and you'll get a notice on all the meetings, and then a copy of all the recordings and a lot of other good stuff that John comes up with in that newsletter too. So
Okay, I just want to repeat it. It's a ppsadvocacy.com.
ppsadvocacy@gmail.com.
At Gmail.
It's in the chat.
Okay, very good.
There is one question which I need to ask Crippen, because I've just been going through and there's bits coming up. Are we able to share your slides with people who've attended?
Yes.
That's very excited about that.
Thank you for everybody for listening and giving us the opportunity to present the pathway in it and what it can do. And as I said, you know, keep being your own advocates, keep beating the drums for the whole polio community.
Well done. Good.
Thank you.
Francis, you have your hand up? No, you don't? Okay, you're just applauding.
We're
I got it.
clapping.
Okay, I got it. All right, so thank you once again very much. The meeting next month is a little earlier than usual because in the United States they celebrate Thanksgiving, I think. Is that correct? Somebody help me on that, John?
Yeah, I'm looking. I think we've got it on we've got it on Thursday, the 16th of November. And then the following one will be 14th of
December.
where am I?
It's December.
December. Yeah.
Okay, sounds good. Okay, if there are no other questions, then I appreciate everyone coming today.